Today I will be providing an overview of percutaneous biopsy and drainage procedures. Now, when it comes to these kinds of procedures, there are three general steps: pre-procedure workup, getting to the target, and then performing the intervention. I'm going to start off by talking about pre-procedure workup, but I'm not going to really go into a discussion of laboratory workup, anticoagulation guidelines, and so forth, because that it can be quite institution dependent, and I can refer you to published guidelines by the Society of Interventional Radiology. In general, I do want to highlight three important questions to ask when a request for a procedure comes through. One is, does the procedure need to be done? Second, can it be done? And three, should it be done? In this example, a patient with diverticulitis has an intramural colonic abscess and a request comes in for a drainage procedure. In this particular example, does this abscess drainage need to happen? In this particular case, the abscess is quite small. It is in an intramural location, and it's important to consider that the pigtail drains usually used for abscess drainages have a diameter, the pigtail portion at least has a diameter between 2 and 3 centimeters. And so an abscess this small, measuring a little less than 2 centimeters in this example, will be too small for drainage placement. So in this particular example, antibiotic therapy might be considered before a more aggressive maneuver is considered. In this example, we have a patient with an interloop abscess and an abscess drainage request comes in. In this particular example, can we place a drainage catheter in this abscess safely? And the answer is there is a high risk of causing a bowel perforation by placing a drain through 2 walls of bowel in order to get into this abscess collection. So in this particular example, leaving a drainage catheter would not be possible. However, if there is a need for microbiological sampling, one can safely place a small needle into the collection through the bowel wall with a very low risk of complication. In this example of a large, irregular appearing abscess, the question here is, should an abscess drainage be done? It's important to consider the reason why we place drainage catheters in this example. When a drainage catheter is placed, we aspirate all the fluid that is in a particular collection, and then we leave the drainage catheter in place so that the walls of the collection begin to adhere to each other over time in order to minimize the risk of reaccumulation of the abscess cavity. In this particular example, note that the wall is quite thick and irregular. This is an example of a tumor abscess, and as such, we do not expect that this cavity will involute in the same manner as, say, a diverticulitis-related abscess. In this example, because an abscess won't involute necessarily, once the catheter is taken out, there is a high likelihood that the abscess will reaccumulate. As such, abscess drains placed in these examples might become lifelong catheter placements. And as such, this kind of situation should be discussed with the patient and the referring provider before consideration of placement of a catheter. The second step in a biopsy or drainage procedure would be getting to the target itself, and that can be broken up into 2 parts. First part is choosing the imaging guidance modality to guide the intervention, and 2, choosing your approach. In general, whenever possible, ultrasound really ought to be used because it's just simply faster compared to other types of imaging guiding modalities. You can angulate the probe to achieve many different kinds of planes that may not be achievable with CT guidance. Real-time visualization is afforded by ultrasound during the intervention. There's no radiation. You can use Doppler imaging in order to monitor for intervening vessels. Ultrasound guidance can be combined with fluoroscopy, and there really is no excuse to use another imaging guidance modality other than ultrasound for superficial targets. In this example, we have a sizable thyroid nodule that is essentially 2 centimeters below the skin surface, and we can see direct real-time visualization of a needle placement into the thyroid nodule for sampling. CT, of course, provides excellent anatomic delineation, but just generally takes longer time than ultrasound-guided procedures. Of course, involves radiation, and in many practices, there isn't a dedicated CT scanner for interventions, and as such, when a CT-guided procedure is performed, it is taking away from diagnostic time as well. CT fluoroscopy is available in many units and is somewhat quicker than general going in the room and coming back out to image type of technique. And this sort of CT fluoroscopy quick check method may enable reduction in radiation to both the patient and the operator when CT fluoroscopy is considered. With CT guidance, generally speaking, some sort of marker or grid is placed on the skin. A preliminary scan is performed and an entry site is selected along the grid or radiopaque marker placement, and the angle and depth of needle placement is determined and the skin is marked. Once the imaging guidance modality is selected, you have to consider the approach, and it's important to think of the patient in 360 degrees. In this example, we have a liver lesion biopsy in which an anterior transabdominal approach is selected. Here we have a needle being placed in a pelvic abscess through a transgluteal posterior approach. And here we have sampling of a loculated pleural collection from the flank, or from the side, I should say. In most cases, when possible, a transabdominal anterior approach is the easiest, but that is not always possible. One approach to consider, particularly when it comes to pelvic masses or pelvic collections, is a transgluteal approach. In general, when a transgluteal approach is considered, CT guidance is necessary. Because of the bony pelvis, it is often difficult to visualize targets using the transgluteal approach using ultrasound guidance. When a transgluteal approach is selected, a patient is placed in the prone or lateral decubitus position. And it's important when placing the needle to consider that generally speaking, the safest and most comfortable route of needle placement will be as close to the sacrum or the sacrococcygeal margin as possible, and when possible, below the piriformis muscle. When keeping the needle close to the sacrum or sacrococcygeal margin, you're more than likely to avoid traversing through gluteal vessels in the sciatic nerve, and which of course reduces bleeding and pain. And if you keep the needle below the piriformis, it generally reduces intra-procedure and post-procedure pain. And just as an aside, this is just a reference to where the piriformis is on CT imaging. So in this example, we have a large pelvic abscess, and an transabdominal approach is determined not to be safe, so a transgluteal approach is selected. As you can see on this image, a needle is placed along the sacrum or sacrococcygeal margin, avoiding the inferior gluteal vessels and the sciatic nerve that is located more laterally. Transvaginal approach can be considered for adnexal lesions or specific abscesses and can be performed with endovaginal ultrasound imaging with the endovaginal probe connected to a needle guide. The patient is placed in a dorsal lithotomy position using stirrups, and the patient is asked to empty the bladder before the procedure. It's important to bear in mind that this is not for presacral collections or presacral lesions, because the rectum would be in the needle path. And in this example, we have a patient with a large loculated left adnexal collection, and using transvaginal ultrasound guidance, we place a needle using Doppler imaging to watch for any intervening vessels to sample and decompress the fluid collection. Transrectal approach may also be considered in a similar manner to transvaginal approach, and is probably most commonly used for prostate biopsy. The major difference here is that the patient is generally placed in the left lateral decubitus position. And in this example, we see a needle. This is the needle guide, and a needle is placed within the prostate gland for biopsy. Transperitoneal approach is becoming more commonly utilized for prostate biopsy and is also being increasingly used for prostate fiducial marker and rectal spacer placement. And similar to the transrectal approach, an endorectal probe is placed, but in distinction to transrectal approach, the patient is actually placed in the lithotomy position using stirrups in order to enable needle placement in through the perineum while imaging using an endorectal probe. Now, the third step in a biopsy and drainage procedures is performing the actual intervention. So we're going to start off by talking about biopsy procedures, and there's several general indications that most of us are familiar with. One is to evaluate diffuse parenchymal disease, such as to evaluate the amount of fibrosis in the liver, a question of cirrhosis, that would be termed a non-focal liver biopsy, to evaluate for cancer, to obtain sampling for microbiological analysis. There are three general biopsy techniques, with the first two being more common. That is the single needle technique and the coaxial needle technique, and we'll quickly touch upon the tandem needle technique. With the single needle technique, this technique involves direct placement of the needle, of the biopsy needle itself, into the target itself. Because there is a single stroke of that biopsy needle straight into the target itself, this is most commonly used with real-time imaging using ultrasound guidance, and is, as exemplified earlier in the talk, really geared for superficial lesions as well as diffuse parenchymal non-targeted lesions such as non-focal liver and non-focal kidney biopsies. Coaxial technique is great and is often considered for deeper seated collections, or for collections in which multiple samples are required, so multiple biopsy passes are required. So you can consider a situation in which a liver mass needs to be biopsied and multiple passes are required. If the single needle technique was utilized, then that would entail multiple punctures of the liver capsule itself, which might increase the risk of bleeding and increase the risk of pain. With the coaxial needle technique, a larger bore introducer needle is first placed into the target lesion itself. This inner stylet is removed, and then the biopsy device itself is passed through the introducer needle, and as many samples as required can be obtained with only a single pass through the liver capsule. Same may apply for a kidney lesion biopsy as well. Ultrasound or CT guidance may be utilized, and again, the main benefit is that it minimizes the number of times that one has to traverse through intervening structures. And briefly, a tandem needle technique is rarely used, and entails placing one needle into the lesion and then using your biopsy device and advancing that biopsy device alongside and parallel to the first needle. And multiple passes can be performed if needed using the first needle as a guide. Of course, this technique entails multiple punctures through a liver capsule for liver lesion, or in the instance of a renal mass, the renal parenchyma may need to be traversed multiple times with this technique, and so it is rarely used. There are many different types of biopsy devices and biopsy needles available. Generally speaking, there are needles that are utilized for fine needle aspiration, or the aspiration of cells, and these are generally small gauge needles that range from 22 to 25 gauge. And then there are core biopsy needles in which pieces of tissue are removed, in which the actual tissue architecture is preserved for histologic analysis. And in most interventional practices, the core biopsy devices used will range from 14 or 16 to 20 gauge. So we're going to, at this point, talk about specific applications when it comes to biopsy, and importantly, in these applications, what can we do to maximize procedure success and minimize complications? In this example, we have a patient with a large liver mass. In this example, you see that there is quite a bit of ascites, and that this mass extends to the liver capsule itself. In this particular example, what we want to consider doing is aspirating the fluid around the liver itself in order to reduce the distance to the target, and then in addition to help reduce the risk of bleeding. There is some belief among operators that the ascites might increase the risk of hemorrhage after liver biopsy, possibly due to the lack of apposition of the capsule or liver surface to the abdominal wall. In addition, we try to, when possible, to place a needle through normal parenchyma first before entering the liver lesion itself. Presumably, the normal parenchyma itself would have normal blood vessels as opposed to the tumor-related vessels within the lesion itself that might be at higher risk of bleeding, and as such, that might reduce the risk of post-procedure hemorrhage. In this example, also note the very low density within the lesion itself. When biopsying lesions that may have a necrotic center, it is important to target the periphery of the lesion in order to increase the chance that you have viable tissue for positive pathological evaluation. Here in this example, we have several lesions near the diaphragm, and a needle is placed using CT guidance, and note that the needle is inadvertently placed through parenchyma, lung parenchyma, and a small pneumothorax occurs. As such, for diaphragmatic lesions, whenever possible, ultrasound guidance should be considered. When ultrasound imaging is not possible because the lesion is too small or it can't be visualized, CT guidance may be performed, and one may consider the use of gantry angulation, angulating the gantry so that the needle trajectory is such that it's going from caudal to cranial toward the diaphragmatic lesion itself. When transpleural transpulmonary approach cannot be avoided, then just be prepared for pneumothorax, and this is where informed consent is important, and discussion with the patient regarding the potential for the need for a chest tube is required. Here we have a patient with a right-sided renal mass. And so how would you position this patient for biopsy? For generally speaking, renal, adrenal lesions or suprarenal collections or masses, we generally use coaxial technique, and we place the ipsilateral side down. That is, in this case, the right side down on the table. What this helps with is it reduces diaphragmatic excursion and displaces lung. In that way, it reduces the chance that your needle path will go through lung, and it also increases the chance that you'll be able to enter the lesion within the kidney without requiring multiple pokes, because the excursion of the diaphragm and the kidney itself is reduced. In this example, we'll show a CT-guided technique in which the grid is marked after a preliminary scan, and an introducer needle is placed within the lesion itself. And here we see the tip of the introducer needle right at the tip of this renal mass. And once we've confirmed appropriate placement, this 22-gauge Chiba needle is placed for fine needle aspiration, with CT documenting appropriate position. And then subsequently, 18-gauge core biopsies are obtained. And in this image, you can see the trough or the cutting portion of the needle through the actual renal mass itself. Perhaps one of the most challenging biopsies are mesenteric lesion biopsies, and the reason for that is that they can be quite mobile. And so whenever one places or advances a needle into a mesenteric nodule or node, the node or nodule may move away, and it becomes similar to bopping for apples. In some instances, the chopstick method may be helpful, in which one needle is placed alongside one aspect of the node or nodule, and then the biopsy needle is placed on the other side, with the first needle being used to keep the node or nodule in place. In this example, we have a patient with a diaphragmatic liver lesion seen on MRI, but on CT is poorly visualized without IV contrast. Do you cancel the biopsy? And in this case, of course, we don't. For liver lesions or even renal lesions in which the lesion is poorly seen without IV contrast, one can place an introducer needle based on anatomic landmarks, comparing the preliminary images from a procedure scan which contrast is not yet used, and the prior CT or MRI in which contrast was used. Once the needle is in a proximate position based on anatomic landmarks, IV contrast is administered during the biopsy procedure. And at that time, either the needle that has been placed can be adjusted to get to the lesion itself if it were very close, or if it were quite far, that first needle can be left in place, and a second needle advanced into the lesion using the first needle as a reference or a marker needle. In some practices, however, fusion software is available, in which case a preliminary or prior CT or MR can be fused with intraprocedural imaging, such as ultrasound imaging, in order to increase the chance of getting into the lesion itself. So in this example, a needle is placed using anatomic landmarks into the approximate position of where the mass is, and then IV contrast is subsequently given, and in this case, the needle is readjusted in order to get into the lesion itself. In terms of specimens, cytology and pathology is generally submitted. The need for cores or pathologic specimens may be dictated by whether intra-procedure cytologic evaluation is performed in the procedure room or during the procedure itself, in which case the pathologist may say, I need more samples, or I may need a core. And there are practices in which pores are obtained in every case whenever possible. It's important to keep in mind that when you're evaluating for lymphoma, that samples are generally kept in saline rather than formalin in order for flow cytometry to be performed, and not to forget to send samples for microbiological analysis if an infection is in the differential diagnosis. Moving on to aspiration and drainage. Sometimes referring providers are confused with the terms aspiration and drainage. It's important to sort of set the tone in order to clarify what actual procedure is requested and required. Generally speaking, when aspiration is performed, we are removing all the fluid within a collection, or at least a sample of the fluid from a collection, using either a needle or catheter. But when a catheter is used, the catheter is not left in. In that case, we call it an aspiration. Any case in which you leave the catheter left in at the end of the procedure, that is referred to as a drainage procedure. Indications for drainage include, of course, treatment of abscess, characterizing a fluid collection, whether that might be a hematoma, seroma, lymphocele, urinoma, myeloma, pancreatic leak, or an empyema, and then, of course, alleviation of symptoms, sometimes pressure sensation, that sort of thing. There are some contraindications, including uncorrectable coagulopathy, lack of safe access, keeping in mind that example earlier in the talk of that interloop abscess, and of course, that tumor abscess that requires a specific discussion with the patient and the referring provider. Most abscess drains or drains placed by interventionalists range in size from 18 to 14 French. And are pigtail or locking pigtail drains. So slightly larger drains may be placed for chest tubes, and for in particular tenacious collections such as colonic leaks or necrotizing pancreatitis, or what we call walled-off pancreatic necrosis, even larger catheters up to 24 French may be placed. Keeping in mind that larger type catheters often don't have a Luer lock connection, in which case regular flushing of the catheter is a little less convenient. This is an example of a few types of drainage catheters used by many operators. This is a 7 French catheter here that may be used for a paracentesis or thoracentesis procedure. This is a 10 French pig-locking pigtail type drain that might be a workhorse drain for many abscess drainages. And this is a large bore 18 or 20 French drain that may be used for something like necrotizing pancreatitis. Another type of drainage catheter to keep in your back pocket for certain kinds of collections is a biliary type drain. And what's nice about biliary drains is that they have numerous side holes, up to 32 side holes, and that might be quite useful for very long fluid collections. One can envision an abscess or collection involving the entire right or left paracolic gutter, in which case placing a long drain with numerous side holes, such as a biliary type drain, into that collection would maximize the surface area of drainage. There are 3 general techniques for abscess aspiration and drainage. That includes direct and tandem trocar, as well as Seldinger technique. Direct trocar technique for drainage procedure involves loading the drainage catheter on a sharp stylet and using real-time ultrasound guidance, advancing that drainage catheter on that sharp stylet directly into the collection, and then once in, unscrewing the stylet and advancing the catheter into the collection. In this example, in a patient who had a renal transplant, there is a perinephric collection, and under ultrasound guidance, a catheter is placed using direct trocar technique right into that perinephric collection, and Doppler imaging may be performed in these instances to look for intervening vessels, such as, say, the inferior epigastric vessels. Tandem trocar technique can also be considered and is important, particularly for more deep-seated lesions and lesions in which CT guidance is being used for drainage procedure. With a tandem trocar technique, a small needle such as a 20-gauge tuba is first advanced into the target using CT guidance. And the thinking here is that it's quite difficult to cause major injury if you inadvertently hit liver, if you inadvertently hit or go through small bowel. If you do that with a 20-gauge tuba or a small needle, the risk of complication is exceedingly low, whereas advancing a catheter on a large stylet and inadvertently going through liver or going through kidney or going through bowel could cause have a higher risk of causing complication. So doing the hard work first of getting a small needle that is unlikely to hurt anything into the collection first is performed with CT guidance. Once that's done, then examination of the skin surface 360 degrees around that needle, and then synthesizing the images obtained on CT will help you select a location along that 360 degree axis around that needle, and then marking that spot adjacent to the needle and advancing your drainage catheter on a sharp stylet by a prescribed depth as measured on the CT scan. And I'll show you an example of that here. In this patient who has a post-API abscess, a 20 gauge Chiba is first placed using CT guidance into the collection. The skin area around that needle is examined in a 360 degrees around the needle and then synthesized with the CT scan in which the needle has been placed. The 12 o'clock position is selected relative to the first needle for drain placement, and the depth between the skin and the collection is measured on CT and marked on the catheter itself. The catheter is then loaded on a stylet and advanced through the skin muscle into the collection and then fed off into the collection itself. And then, of course, most operators are familiar with Seldinger Technique, which can be performed with ultrasound or a combination of ultrasound and fluoroscopic guidance as well as CT guidance. This is particularly useful for subphrenic collections and large collections in which one is considering placement of a biliary type drainage catheter, in which those types of catheters can only be placed using Seldinger Technique, as they do not come packaged with a sharp stylet for trocar placement. In this example of a right subphrenic collection, the inferior-most perihepatic aspect of the collection is accessed with a needle using ultrasound, and then using fluoroscopy, a wire is advanced into the collection, and an abscess drain, in this case a biliary type drain with 32 side holes, is advanced over the liver into the subphrenic collection. It's important to consider what kind of collection you're draining in order to determine what laboratory samples to send. Obviously, with abscesses, it will be microbiological laboratory specimens. If you're suspecting a bioloma, you can send a sample for bilirubin, urinoma, creatinine. For pancreas or most left upper quadrant collections, particularly after splenectomy, one should consider sending an amylase. Sometimes a pancreatic leak is not known ahead of time and is discovered simply because the operator realized that it was a left upper quadrant collection and thought to send the amylase as well as for microbiological data. For chyle leak, triglycerides, and then of course cytology for suspected malignancy. Now it's also important to talk about when to remove a drain, and that could be almost as hard of a decision as how to place a drain in itself. General guidelines for drain removal include that the patient is clinically improved, no longer has a fever, resolution of leukocytosis. And on imaging, whether that be CT, drain injection under fluoroscopy, or both, the abscess cavity has involuted. There is minimal drainage output, I'd say less than 15-20 cc's output per 24-hour period, and then evaluation for whether a fistula still exists. In this example here, an abscess drain is injected with contrast under fluoroscopy. There is no longer any cavity, but what we do see is a persistent fistula to the pancreatic duct. Now, the presence of a fistula itself does not preclude removal of a drain. So in many instances, a patient in whom the output is minimal, the patient is clinically well, there is no evidence for a residual cavity, and the contrast injection of the drain demonstrates that there may be fistula to bowel or to kidney or to bile duct, depending on the type of collection that was drained. One can consider removing the drain as long as that there is no downstream obstruction of the communicating structure. So imagine a drainage catheter within a bioloma, and the bioloma has resolved. The drain is injected with contrast, and there's communication with the biliary tree and subsequently propagation of contrast into the bowel. The normal downstream flow of what we expect bile, and in this case contrast, to go. If the patient is well, the cavity is involuted, and there is minimal to no output, then one can consider removing the drain, as once the drain is removed, the weight of the tissues will collapse the abscess drain tract, and the path of least resistance for bile will be forward. The main exception to that, as I mentioned, is if there is persistent downstream obstruction, whether there's a bowel obstruction or biliary obstruction, or in this case, pancreatic leaks. Pancreatic leaks are notorious for being persistent and recurring when drains are removed. So in this particular case, when there is a persistent communication with the pancreatic duct, it's important to really be sure that the patient's output from the drain is minimal to none. Any substantial output of pancreatic fluid or pancreatic juices through the drain itself should make the operator be wary of removing the drain too early. In many instances, some operators and surgeons would prefer that the drain in these situations be backed away slowly from the area of communication with the pancreatic duct. There is some belief that a drainage catheter adjacent to the source or area of leak may reduce the healing effect of the hole that's present there. So you may find yourself in some situations being asked to back away this catheter slowly, week by week or every 2 weeks by a centimeter or two, hopefully allowing the tract to close. In this example of a urinoma drain, we see a ureteral stent and a drainage catheter within a urinoma. And in this injection, we see a large persistent cavity as well as communication with the urinary collecting system. This drain is not ready to come out. And in this instance, we see 2 biloma drains that communicate with the biliary tree. And in this particular instance, you see that there's still a persistent cavity. And so in this particular case, the drain would not be ready to come out. It is important to note what factors delay abscess healing so that you can manage both the patient's expectations for how long the drainage catheter will stay in, as well as that of the referring provider. Abscess is drained within a previously radiated field, or abscess related to downstream obstruction, persistent inflammation such as inflammatory bowel disease, tumor abscesses, as mentioned previously, pancreatic leaks, abscesses that are yeast abscesses or infected hematomas are all important factors to keep in your mind that may delay abscess healing. When you recognize that one or more of these factors are present, it's again important to manage the patient's expectations and give them a heads up that this may be a drainage catheter that'll stay in longer than usual. There are instances in which drainage procedure goes quite well, and then a patient nevertheless comes back, or the referring provider calls you and says the patient is still not doing well, leukocytosis persists, and an interval imaging is performed, and you get a picture kind of like this, in which the drain is sitting right in the middle of the collection, but the collection persists. What are some of the things that you can do to help decompress this collection? Some of the things that one can consider is a drain upsize. So certainly if an 8 or a 10 French drain was placed, one can upsize to, say, a 14 French drain. Additional drainage catheters can be placed if collection is large enough. And an important tool in your armamentarium is to recommend the use of TPA. And in this scenario, TPA can be formulated by mixing 4 to 6 milligrams within, say, about 50 milliliters of saline, and then a volume of this TPA solution is injected into the drainage catheter twice a day, with the catheter clamped for an hour after installation and then unclamped. The volume that is actually placed within the catheter should be less than the volume of the abscess itself. So if you know that when you place the drain, approximately 20 to 30 milliliters compose the collection, then it's important not to instill 50 milliliters of a TPA solution, because you can cause a hemorrhagic complication or pain with a volume larger than the abscess itself. And in most instances, the risk of hemorrhage or bleeding complication is extremely low, even in abdominal collections that receive TPA in patients who are already therapeutically anticoagulated. There is, however, evidence of chest or pleural collections that might have a higher risk of bleeding if TPA is instilled into that pleural space while the patient is therapeutically anticoagulated, not prophylactically, but therapeutically anticoagulated. So that factor should be identified before consideration of TPAing of pleural collections. So that summarizes a general overview of biopsy and drainage procedures. I hope that you were able to get some useful information out of this talk, and thank you so much for spending time with me on this.